Hello, everyone, and welcome to the May 2025 episode of Diabetes Care on Air, a fun way to bring the research in diabetes care to life. I'm Alice Chang from the University of Toronto.
And I'm Mike Rickels from the University of Pennsylvania, and we are your co-hosts for this podcast series.
So welcome to May, everyone, and for the Star Wars fans out there, may the 4th be with you.
And also with you.
Oh, well done, Mike. It's a very appropriate response indeed. Well done. So, fun facts, because I always like doing fun facts. May 5th is Cinco de Mayo, which marks the 1862 Mexican victory over the French during the Second Franco-Mexican War. But it is also an excuse to drink, because I read that Americans spend over $600 million each year on beer for Cinco de Mayo, which is more than the Super Bowl or St. Patrick's Day, which I find incredibly hard to believe.
That is hard to believe, Alice. Fascinating. And where do you find your fun facts?
Well, these so-called facts on something called the internet, Mike, and I realize that there may be fake news out there or alternative facts, but I'm enjoying these facts. So I'm going to give you another one for fun fact to share about May. The international distress call, Mayday, Mayday, actually has nothing to do with the month of May. It is actually based on the French term for help me, which is m'aider. Now you have another fun fact for your next dinner party.
Well, so that's what happens with poor French pronunciations at dinner parties, I suppose. On that note, let's help our listeners by getting on with this episode where we will be interviewing authors of feature articles from the May issue of Diabetes Care and run through our popular rapid exchange segment where we will each pick 3 articles of particular interest to us.
And on top of that, we have a special treat for you, which is an interview with the artists responsible for the cover art on this month's issue, entitled Bald Cypress Tree at Aglet's End.
Let's get on with it.
The cover of the May 2025 issue of Diabetes Care features a stunning photograph from Dr. John Buse and Mary Beth Cassely. John is an endocrinologist and director of the Diabetes Care Center at the University of North Carolina at Chapel Hill and a former president of the American Diabetes Association. And Mary Beth is the director of the Innovation Program team at University of North Carolina. Thank you so much to both of you for joining me today and agreeing to be part of this podcast.
It's a pleasure.
Great to be here.
So first of all, congratulations to you for having your artwork featured on this month's cover. Before we discuss the specific image, tell us a bit about yourself and how photography came into your lives and became a common passion for you. So perhaps let's start with John.
Yeah, when I was probably a teenager, my father would take lots of pictures of the neighborhood and kids and the family when we would get together. My grandfather, before that, had done some art photography when he immigrated to the United States in the 1960s. And so I was a little bit familiar with it. In college, I bought a camera and liked taking pictures, but it was kind of an expensive habit because you had to develop the images onto photographic paper. But once these memory cards became available and you could take all the pictures you wanted, I don't do it all the time, but when I have downtime, I do enjoy taking pictures and trying to find, the image that captures what I'm seeing adequately.
And Mary Beth?
Well, my father worked for Polaroid Corporation in Waltham, Massachusetts for about near 40 years. And so growing up, he would bring home all these packages of film that were, I think, expired or had some other issue, but, still usable. So my brothers and I, even pretty young, because that film was expensive, but not when you got packets of it for free. So we would take lots of pictures of, each other, the dog, neighborhood kids. And then one of my brothers actually, became a more serious photographer. But I, then came Kodaks and, I definitely took lots of pictures in college and post-college of mostly of friends. But then, obviously, like a lot of people, when I travel, I would take pictures of things, that I'd see.
And she's become very well known. I go take photographs at her reunions, but she brings binders with pictures going back,
Oh my.
50 years. So she's like the archivist for every group of friends that exists.
And I guess this really speaks to how family has, I mean, I guess obviously family has incredible impact on everything we do, but also in our hobbies and in the passions that we end up developing. And I think that resonates true in both of the stories that I'm hearing from you. Actually, but before we talk about the actual image, I do want to go back to something, John, that you mentioned about how you try to capture what it is that you're seeing. And I have to admit, that's something I struggle with when it comes. I'm by no means a professional photographer, but I also enjoy taking photos, is that I can never capture what my eyeballs can see on the picture. So what is it that you're doing, or how have you managed to do that?
Yeah, I mean, for me, because I'm not a professional photographer either, I think it amounts to, well, particularly the kinds of images that will be on the cover of Diabetes Care. I have probably taken, I mean, at least 100 and probably several hundred pictures of that tree on different days with different weather from different angles. It's a stunning piece of nature. And I have several really amazing pictures of that tree and other trees. The good thing about trees, they don't move around. So
That's a good
you have a
point.
chance to go back many, many times to get the picture right.
That's a good point. Which is a great segue into the featured art for the May issue cover. And it's entitled Bald Cypress Tree at Aglet's End. So, where's the tree? Although I guess the answer is Aglet's End, but maybe you could give us a little more context. And how was the photo taken, and what does it mean to you?
Mary Beth, you tell the best story about Aglet's End.
Right. So the tree is located in the water just off the coast of our home on the inner banks of North Carolina. So we have a home on the Albemarle Sound that we call Aglet's End. It's a little pretentious to have a name for your vacation home, but it came about. Speaking of family, I believe the first Thanksgiving we spent there in 2021, we had all four of our children and maybe a son in law as well. And I told the kids I wanted a name for the house. So we actually had a clipboard where we all were yelling out words like, nautical kinds of words and words about the area, the county, the town. And the way that Aglet got on there is, it's a long story, so I will make it short. But an aglet is the metal tip on the end of a shoelace that keeps it from
Oh,
unraveling.
huh.
Or they used to be metal, I should say. I don't, yeah. And there's right around where our home is some protected land that was bought by a trust and then given to the state. And the reason it's protected is about 10 or 12 years ago, they did an archaeological dig on this property right on the banks of what's called Salmon Creek. And they found a variety of pieces of pottery and other things, including one or more aglets that they dated back to around 1587 that they think could have come from the old colony, the lost colony people that came 40 miles inland and might have been in the area where our home is. So that's a long story to say that Aglet ended up in the list, and I love the movie Howard's End. So, and our house is the last house on the street. So
Makes sense.
we call the house Aglets, and we're fortunate that we're the last house and we have some undeveloped land next to us. And we have a grove, that's the right word, of cypress trees. Many of them are very close to land. And then there's this one tree that's the left-hand tree in the picture. So that one, of course, by itself, is one we take a lot of pictures of. And I tend to be up for the sunrises.
Hmm.
And so I have a lot of pictures taken at sunrise. The sun sets behind us, but we do often get a pretty kind of pink and light blue sky at sunset. So we also take a lot of pictures of the tree at sunset.
So this particular photo then that's on the cover, that one was not a
sunset photo, was it? I don't think that one was a sunset photo. And how did you take it? Did you take it with a fancy camera, with a phone camera, or how was it done?
A phone camera. Well, so at sunset, we don't see the sunset. The
Ah.
sun's setting way behind us. But what we get is these unique sort of colors in the sky. Is that a sunset picture?
No, I don't
John?
think so.
I guess I
I
thought
think
it was.
it's probably
Okay, sorry.
it's a winter picture for sure, because you don't see any of the little green leaves that
Mhm.
are on the cypress tree, and you can sort of tell it's cold. I
Mhm.
mean, or at least I get a sense of when I look at the picture, that it was cold. And the truth of the matter is, we have so many pictures of this tree. There is some uncertainty, but we do have the date, and I think it was December 23rd. And it could be in the middle of the day. It could be at sunrise, but we were taking the picture away from where the sun would rise in the winter. But I suspect it's more mid-morning.
And John, why trees? You said you particularly like taking pictures. I mean, one is they don't move. You did mention that, but what else about trees and flora that interests you?
I don't know. I've always been struck in the spring, in particular, with all the different shades of green. You look at a forest, or where I grew up in South Carolina on the coast, and where I live now in North Carolina in the foothills and in the Piedmont area it's called, and now on the coast, you have these long views that you can see, and then trees in the distance, and you can just see hundreds of shades of green that each of the trees have. And then there's the shape of the tree and the bones of the tree, the branches. And in the winter, you see the bones of the tree. And in the summer and the spring, you see the shape of the tree. And then sometimes it has snow on it, or sometimes, it's blowing around in the wind. And I just find them beautiful. I love flowers. That may in part come from my father, who was a rose gardener and a wildflower gardener. We went on a safari in Africa, and it was very interesting. It was three couples for part of it. The guy in one of the couples is a birder, and he had this amazing camera and would take pictures of, hawks swooping around, from hundreds of yards away. And then most people were taking pictures of the lions and the rhinoceroses and the giraffes and the zebras. And I was taking pictures of trees. So it was just interesting how six people who took a lot of pictures have their sort of favorite kind of pictures to take.
So, my final question to both of you is what would you say to someone listening to this podcast right now who's thinking about submitting their art to be considered for a cover for diabetes care, but maybe just not sure? What advice would you have for them?
Well, first, I'm one of the deputy editors of Diabetes Care, and it was really, I think, Stephen Kahn, the editor's brainchild, these cover images. And what we've always thought is we want people who have a connection to diabetes, people living with diabetes, people supporting the lives of people living with diabetes, professionals that are dedicating their career to diabetes. That's probably number one, is some connection to diabetes. And the number two is, if art of whatever kind, we've had tattoos, we've had photographs, we've had paintings, we've had wall graffiti type stuff, whatever speaks to you, please share it with us. We love these images. Some of them have been absolutely stunning. My tree is pretty good. I'm not even sure it's my best tree, to be honest. But if you come visit us on Bertie County, just across the Chowan River from Edenton, North Carolina, the big town next door that's got 3,000 people in it,
Wow.
we'd love to show you the tree and some of our efforts at taking pictures of it.
There you go, everyone. There's an invitation from John and Mary Beth to visit the tree. So thank you. Thank you to both of you for sharing your time and your talent with us. And for anyone listening who has original art they wish to submit, please email the ADA at productionmanager@diabetes.org or visit the Diabetes Care website for more information.
In the May 2025 issue of Diabetes Care is a feature article discussing the modern role of basal insulin in advancing therapy in people with type 2 diabetes. I'm delighted we have joining us the article's first author, Professor Geremia Bolli. Professor Bolli is an endocrinologist at the University of Perugia in Italy. Welcome, Geremia.
Thank you very much, Dr. Rickels, for your kind invitation to give comments on our recent review article paper on basal insulin in type 2 diabetes, and give us the opportunity of better explaining the reasons why basal insulin treatment is really so important.
And first, congratulations to you, Geremia, and your co-authors on your feature article. To get started, Geremia, your lab has had a long-standing interest in the use of basal insulin for the treatment of diabetes. What prompted your writing an updated review on the role of basal insulin in type 2 diabetes at this time?
We have been doing clinical research for more than 2 decades on basal insulin, particularly on pharmacokinetics and pharmacodynamics of the new long-acting insulin analogs this century. My colleagues and I have decided to write the present review to remind the great benefits of basal insulin in the treatment of type 2, even in the present era, where the new drugs, GLP-1 receptor agonists and SGLT2s, are preferred usually to basal insulin as recommended by the international scientific societies. Basal insulin treatment is often necessary in type 2 diabetes to maintain glycemic control over time, even in the presence of use of GLP-1 receptor agonists and or SGLT2s.
And it's so important to be reminded of the benefits of basal insulin use in type 2 diabetes. And Geremia, can you highlight a few of those benefits that are most important for diabetes providers to keep at the top of their minds?
Yes, basal insulin is really the endogenous hormone which is missing in type 2 diabetes. Basal insulin treatment is a replacement therapy similar to the replacement of other hormonal deficiencies in endocrinology. Basal insulin, in addition, is the most powerful treatment to normalize fasting and often to improve postprandial blood glucose. Basal insulin treatment has lifelong durability. There are no contraindications to use of basal insulin, and basal insulin can be associated with any other glucose-lowering agent except maybe pioglitazone. Basal insulin improves beta cell function and improves insulin resistance, leading often to diabetes remission when initiated early after type 2 diabetes onset. In addition, by maintaining glycemic control to the target over the years, basal insulin has long-term protective cardiovascular and renal effects.
And you mentioned how basal insulin can be used with other classes of glucose lowering agents. And your article goes further in discussing complementary use of basal insulin together with other glucose lowering agents. Can you please provide a few examples where combining therapy can improve glycemic control further while at the same time mitigating risks of one or the other agent?
Thank you for this important question. The different mechanisms of action make it possible and desirable to combine basal insulin with GLP-1 receptor agonists and or SGLT2s. For example, basal insulin regulates primarily fasting blood glucose, whereas GLP-1 receptor agonists regulate primarily postprandial blood glucose. Thus, the combination of the two has relevant complementary effects on blood glucose regulation, with less weight gain and lower risk of hypoglycemia. Similarly, the add-on of basal insulin to SGLT2s not only improves blood glucose, but also restores the anabolic status while reducing hypoglycemia risk and risk for DKA. Importantly, GLP-1 receptor agonists and or SGLT2s added to basal insulin help cardiovascular and renal protection in the short term.
And so that's so important to understand how combining therapies can minimize the concerns related to hypoglycemia and weight gain that have been barriers to implementing insulin therapy in type 2 diabetes. And your article also discusses how these potential adverse effects can be further minimized by careful initiation and titrating of basal insulin. Can you talk us through how you go about implementing basal insulin therapy safely in your patients?
Yes, hypoglycemia and weight gain are the traditional, well-known drawbacks of any insulin treatment. This has been inherited from the remote past. However, this applies primarily to rapid-acting prandial, not to the basal insulin preparations. The modern long-acting insulin analogs do not cause weight gain, at least clinically relevant, as the randomized trials indicate, and severe hypoglycemia really never occurs. However, it is important to titrate cautiously and in a conservative way basal insulin and to rely on a safe algorithm of titration to prevent nocturnal hypoglycemia.
And Jeremiah, how about in pre-diabetes? Should we be thinking even earlier about implementation of basal insulin for individuals at risk for diabetes development?
Well, treatment, of course, should be initiated very early in the natural history of type 2 diabetes, even at the stage of an IFG and IGT, the so-called prediabetes status. Of course, with initially lifestyle intervention and usually metformin. If obesity is present, and as usually does, then GLP-1 receptor agonists should be considered, of course. However, if fasting plasma glucose continues to increase even modestly over time, the early add-on of basal insulin would be the right move then.
That's really helpful guidance and so important for our patients. And are there other special situations where we should advocate considering basal insulin for our patients with type 2 diabetes? And any other takeaway messages you have for our listeners?
Well, as I said already, and I like to remind it, basal insulin is the replacement of the natural hormone missing in type 2 diabetes. Under this aspect, basal insulin replacement is a natural therapy. And over time, basal insulin becomes the indispensable add-on treatment to maintain glycemic control when the other therapies fail and HbA1c is off target. This requires, of course, knowledge about how to best use basal insulin and knowledge how to titrate safely basal insulin. It is fundamental to continue titration over time since the needs of basal insulin vary as time goes by.
And such an important note for that follow-up and ability to use this therapy in a variety of situations, as well as adjusting the therapy as the needs of our patients change over time. And having grown up myself a staunch advocate of early initiation of basal insulin, largely based on your group's work, Geremia, over the years, I really appreciate your data-driven review of the merits and the how-to for implementing this approach. And really, thank you, Professor Bolli, so much for sharing your expertise with us today. I want to encourage our listeners to access the full article in the May issue of Diabetes Care.
One of the feature articles from the May 2025 issue of Diabetes Care is an original article entitled Derivation and Validation of D-Risk, an electronic health record-driven risk score to detect undiagnosed dysglycemia in clinical practice, by Dr. Michael Bowen and colleagues. I'm joined today by Dr. Michael Bowen, Associate Professor in the Departments of Internal Medicine, Pediatrics, and Population and Data Sciences at UT Southwestern Medical Center in Dallas, Texas. Thank you so much for agreeing to be part of this podcast, and congratulations to you and your collaborators.
Thank you so much, Alice. It's a pleasure to join you today on Diabetes Care on Air and really to have the opportunity to discuss D-risk.
So, Michael, guidelines have existed for quite some time in terms of screening for diabetes. So, what was the inspiration then behind this particular project, and why do we need another risk score?
So we use diabetes screening guidelines all the time, and they really help us identify people that are at high risk for diabetes based mostly on their demographics and comorbid conditions. And although these can be really helpful, it can become challenging to actually translate these into clinical practice, especially in primary care, where the overwhelming majority of our diabetes screening occurs. It gets really nuanced as this. As a general internist, the vast majority of my patients actually meet the ADA screening criteria for diabetes. However, a lot of these people end up not having diabetes and have normal test results when we screen them, despite having multiple risk factors. This is because the ADA screening guideline is highly sensitive, but the overall specificity for it is quite low to detect diabetes. This actually leads to a large number of false positive screenings, meaning that the screening guideline actually identifies the patient as high risk, but their test result comes back normal. And as a primary care provider, this isn't the most helpful thing for me. And in fact, we do a pretty good job of identifying who the high risk people are in clinical practice. And our team has actually previously shown that a lot of times providers don't seem to use the screening guidelines to actually target screening that they do in clinical practice. So this can actually lead to a lot of high risk patients potentially falling through the cracks. And so, as we think about this in the context of a healthcare system where patients actually receive longitudinal care over time and have multiple opportunities for screening, we probably don't need a highly sensitive test because the consequences of missing diabetes screening over a period of time is much lower than if it were a one and done opportunity. And so, as we think about diabetes risk score, even though we have many of them in the literature, most of them are actually not designed to be used in clinical practice. This is because most of these require patient reported data or the additional collection of data in order to calculate the risk score. And this can be really challenging in primary care, where clinical staff or healthcare providers might have to spend extra time collecting information during the context of the encounter, which can prohibit their use. And so, what we really need are guidelines and risk scores that are not only useful, but also usable in clinical practice. And these existing diabetes risk scores, I would argue, are really not designed for use in clinical practice. And this was the critical gap that we sought to fill with the development of D-Risk, where we wanted to leverage commonly available structured EHR data to identify patients at high risk for diabetes.
So, how did you and your colleagues go about deriving your risk score then? Because you make a very strong argument for why we need another one, or I should say, we need one that is more clinically useful. So, how did you go about doing this?
So, great question. So, I think it's actually helpful to think about the impetus for the entire development of D-Risk, which actually came from one of my primary care patients. And so, in addition to being a primary care provider, I'm a health services researcher, but I also have a background in quality improvement and implementation science. And this really shapes the lens through which I approach both clinical care and research. So, several years ago, I was actually seeing a new patient in my primary care clinic. And as I was getting to know him, going through the course of the visit, doing all of our routine things, updating his medical history, family history, social history, medications, etc., I started reviewing his labs. Now, this particular patient had actually been seen in our health system for many years. He had a very complex medical history and he had seen lots of specialists, but he had never seen a primary care doctor before. So as I'm scrolling through his labs, I noticed that his recent glucose was in the 160s. And then I started looking back and realizing that for many months back, they were all in the 140 to 170 range. And so, even though I had just reviewed his medical history and he didn't actually mention diabetes, I thought it was maybe just something that he'd forgotten to mention. And so I actually then asked him, if he had prediabetes or if anyone had ever mentioned that he had elevated blood sugars. And his response was so poignant and it really launched the formative work for D-Risk. Because he said, you, meaning the healthcare system, check my blood all the time. Nobody has ever told me I have a problem with my sugar. And so in the EHR, I clicked on the button to graph his random glucoses. And sure enough, he probably had 8 to 10 years of glucoses that were bouncing all over the place. And in probably the past 3 to 4 years, had all been in the 140 to 170 range. And as you can imagine, there was this kind of awkward pause where I was trying to figure out what to say. And all I could actually say was, you know what, you're right. We check your sugar all the time. And a lot of these blood sugars are higher than I think they should be. We should probably test you for diabetes. And sure enough, later that afternoon, his A1C came back at 7.6%. And it was really one of those strange moments where I realized that we actually had all of the data that we needed to identify this patient long before we made the diagnosis. We had a high index of suspicion, I could argue, and it had just been sitting there accumulating in the EHR over the years. And so I asked myself, how did we miss all of this data? And so the clinical research and healthcare improvement aspects of my brain went to work, and I just couldn't stop thinking about this. How long had he actually had diabetes before I recognized this? Why did we miss this? And then I realized that actually all of the glucose values in the EHR that I was looking at were random glucose values, meaning that they were not fasting that I could tell. And as the interpreting clinician, you have no idea when or what the patient had to eat or drink at any point before they had their blood work done. And as I thought about it a little bit more, there's actually no clear guidelines on how to interpret or utilize random blood glucose values in clinical practice. If we think about the ADA standards of care, if it's greater than 200 with symptoms, we know it's diagnostic of diabetes. We probably don't miss very many of these because the patients are symptomatic or the value is high enough to trip our alarm bells and contact the patient. But what about all those values in between 100 and 199 that my patient had had? So this was really intriguing to me. And, I started looking in the literature and there's a little bit of work on random blood glucose, but not a lot. And then I started even asking myself, what is normal? And when we looked at the reference ranges, it's interesting that the reference range for random glucose is either set at 140, which is based on OGTT criteria, where we assume the patient was fasting, had a designated glucose load with a carefully timed 2-hour test to measure their glucose in a specific way. However, this isn't what these values represent in clinical practice. So we're using this 140 threshold is abnormal based upon a flawed assumption. Sometimes, even in older values, you'll see a random glucose level of 200 flagged as abnormal, which is based upon the diagnostic criteria for diabetes. So I made the argument that really we can look and understand these random glucose values and really use them as a high index of suspicion to detect undiagnosed diabetes. And I always joke with my trainees when I look at their lab results with them and ask them what the glucose was. And they say, we don't know. And I was like, well, you ordered a basic metabolic panel or a comprehensive metabolic panel. They're like, yeah, we just wanted to know what the electrolytes and the renal function were. And it makes the point because the glucose is actually the hidden value that gets ignored because we never order laboratory panels for the glucose. So this is really readily available, largely ignored and under-recognized data that we really wanted to harness to help identify people with undiagnosed diabetes and prediabetes. So early on, my team and I did a series of studies actually trying to understand the relationship between random glucose and undiagnosed diabetes. And doing some early work in the National Health and Nutrition Examination Survey and EHR data, we actually showed that there's a strong dose response relationship between random glucose elevations and the odds of having undiagnosed diabetes and prediabetes, as you might expect. And if you actually examine the relationship between when was the last time they had any caloric intake and their glucose levels, those with unrecognized dysglycemia actually have significantly higher random glucose levels at all time points than those who have normoglycemia. This really reflects what we know about glucose regulation in our bodies, because as we lose regulation, those early values in the postprandial states start to have larger and larger excursions where we can really catch those peaks and valleys on these random glucose values as people show up for routine blood work. And finally, we did some early work also showing that a single random glucose value of greater than or equal to 100 in a patient without diagnosed dysglycemia was almost 80% sensitive and 80% specific to identify patients with undiagnosed diabetes. This actually is an overall C statistic, an index of discrimination, performed better than diabetes screening guidelines. However, when we wanted to focus on the detection of dysglycemia, random glucose was really similar to the screening guidelines. So that's where we really set out on the journey to develop DRISC and ask the question, how can we utilize random glucose values and other structured EHR data to develop a more practical risk score for use in clinical practice?
So after deriving D-risk, you now had to validate it. So how did you go about validating it?
So as we set out to develop DRISC, we wanted to build a good model, but we were not obsessed with building the perfect model. And this is really important because we wanted to make this practically useful in clinical practice. And so we purposely focused on the structured EHR data, and we didn't want to have to rely on additional information reported from patients or collected during clinic visits. In our derivation sample, we actually used an EHR data extract from Parkland Health, which is a large integrated safety net hospital in Dallas. And we designed this sample to really mimic the primary care setting in which screening would occur. So we identified an index visit, identified the predictor variables at the time of that visit or historically, and used their last random glucose data prior to that visit as the primary predictor. We then selected the A1C value after the clinic visit as the outcome to help adjudicate the diagnosis of dysglycemia or normoglycemia. And we selected our candidate predictors really based upon the clinical relevance to diabetes risk and, perhaps most importantly, consistent data capture in a reliable fashion. So, working with our expert team, we identified age, sex, race, BMI, a diagnosis of hypertension, a family history of diabetes, and the patient's most recent random glucose values as our candidate predictors that we wanted to use to construct the model. We then built a stepwise regression model to examine this and ultimately converted the regression coefficients to points using the Framingham approach for the original Framingham risk score for cardiovascular risk. And we did this because we wanted the point system to be readily accessible to clinicians and decision makers, and also to facilitate its programming and use into the electronic health record in an easy manner. And so at the end of the modeling, in our final model, age, race, BMI, hypertension, and the last random glucose value were the variables retained and ultimately used to create D-risk.
So after deriving D-risk then, which was now 5 variables, you had to validate it. So how did you go about validating it?
So because we derived it in the EHR data, we knew that there were potentially intrinsic biases in these data. And this is because in the EHR, we really only document the presence of diagnoses or risk factors. But implicit in that is that we asked for the presence of those, which we know we oftentimes do not. So in our validation sample, we really wanted to use a prospective diabetes screening study. And so we conducted a prospective screening study of 500 primary care patients from the same health system who had no evidence of diabetes screening or diagnosis of diabetes or prediabetes. We brought them in and had them complete a hemoglobin A1C to adjudicate the outcome. And then we utilized their baseline predictors to build D-risk. However, in the prospective cohort study, we used patient-reported data on risk factors rather than the EHR collected data on risk factors, with the exception of the random glucose, which we used from the EHR.
And how did D-risk then perform compared to other established risk assessment tools?
So D-risk performed quite well. For the overall model, the C statistic in the validation sample was 0.74 to detect cases of prevalent undiagnosed dysglycemia in clinical practice. And it's important to know, because we recruited from people engaged in clinical care, this is detecting disease in individuals who have been to primary care and, for whatever reason it may be, were not screened. So this is really powerful because it's really filling the gap, and the performance of D-risk is indicated on that gap of people seen in primary care but not screened. And as we looked at the performance of D-risk relative to other screening guidelines, we examined it compared to the ADA and the US Preventive Services Task Force screening guidelines. So the discrimination of D-risk was actually significantly higher than either of those guidelines to detect prevalent undiagnosed dysglycemia. We also wanted to compare it to the ADA risk test, which is an actual risk score similar to D-risk in principle. However, the ADA risk test is a purely patient-facing tool, meaning it requires patient-reported data in order to calculate it, because it contains information such as physical activity and gestational diabetes that are not commonly captured well in EHR data. And so when we used our validation cohort of patient-reported data, D-risk actually performed quite similarly to the ADA risk test. However, the caveat here is D-risk can run independent of patient-reported data using purely structured data, whereas the ADA risk test would require the supplement of patient-reported data in order to calculate it accurately. And so a key strength of D-risk is that it allows users to actually select a risk threshold for testing. For instance, in our health system, we partnered with our primary care and diabetes leaders and identified a point score of 9 or greater as a cut point applicable to our health system. And we really chose this based upon our perspective of our overall diabetes risk in the health system, but also the available resources and willingness to screen threshold. And so using this cut point of 9, it would recommend screening for 56% of primary care patients who had not already been screened for diabetes in clinical practice. So again, we take everybody in clinical practice that is screened, then we look at those who were not screened, and it would recommend screening for 56% of those individuals. And using this cut point, the sensitivity was 75%, and the specificity was 53%. And just in contrast, the American Diabetes Association screening guidelines in our health system would actually recommend screening for 97% of the population. And it would be 99% sensitive, but the specificity would only be 4%. So we really wanted to achieve a better balance of sensitivity and specificity for our health system purposes. And de-risk really allows the user to select that cut point that is appropriate.
And it sounds like you and your group were successful in driving a risk score that had, as you said, greater balance between sensitivity and specificity, which is fantastic. But perhaps this is more of a philosophical question that I'm asking you then. As a global healthcare community, are we prepared to identify all the people living with prediabetes or diabetes? Because that is what your score will ultimately help us do, is identify more. Obviously, cannot identify everyone, but it's a better tool in terms of identifying those with prediabetes or diabetes. But is that something we can handle?
So I think this gets really challenging in the global community. In order to achieve this goal of, better identification and screening of all people with diabetes and prediabetes, we really need even more risk assessment tools and screening strategies in our toolbox. And I really view de-risk as just that. It's a new tool in our toolbox. But I think it's important to think about it in terms of its use case. It is specifically designed for clinicians and health systems who have EHR data. And it really only applies to patients who are actively engaged in clinical care. And because of this, I actually think de-risk has great potential to improve risk assessment and screening across diverse health systems. And de-risk itself could potentially decrease screening, because if we actually followed the risk thresholds that were selected by health systems, we may screen less than the routine screening that clinicians do in clinical practice. Because oftentimes, clinicians and health systems screen on the order of 70% of the population in the health system. But with a better tool to identify and stratify risk, we might be able to screen less with a higher yield. But again, this really only applies to health systems with EHR data. And I think as we move towards more community settings and global communities, especially developing countries, we really need clinical and research leaders to rethink how we approach risk assessment, screening, and linkage to care in those settings, because those individuals oftentimes are not engaged in healthcare services on a regular basis. And this is actually a much more challenging task.
A great point. Great point indeed. Now, just so I'm clear, with the de-risk score, given that it's designed with the EHR in mind, it can run on its own? Like, is this a situation whereby a clinician could then apply de-risk into their EHR, and then you pop up a list of individuals that should be screened? Is that how it, in other words, the automation component of it?
That's a great question. So we purposely designed it so that it would be versatile enough to be automated. And right now, our team is actually working to figure out what are the optimal ways to utilize and deploy de-risk in clinical practice to improve screening and health outcomes. So right now, it's a risk algorithm, just like any other risk algorithm or model that we can build and publish. but how do we actually put that into action? So, a couple of things that our team has been working on is we are really interested in leveraging de-risk to run population health, meaning we take an entire healthcare system and we risk stratify those individuals who don't have diagnosed diabetes. Then we can use that to actually conduct targeted screening and outreach strategies to try and close those screening gaps among high risk patients. So, right now, we're actually conducting a large system level pragmatic trial that is utilizing de-risk in a population health diabetes outreach screening program. And as part of this program, we have actually programmed de-risk into the electronic health record and linked it to infrastructure such that we can actually place bulk orders for diabetes screening. So, with the click of a button, we can place hundreds of orders for hemoglobin A1C. And then we actually conduct outreach to those patients. And we're studying the optimal ways to do the outreach to patients to get them to come in and complete those screening tests so that we can try and close these screening gaps. So that's just one example of where a next step we are thinking that de-risk may be useful. However, there are a number of other ways that it could be deployed for individual clinicians as visit-based care, or even as other instruments to deploy as well.
So it's brilliant, right? I mean, it's simpler, smarter screening that can be automated. I mean, if I could sort of summarize what I've heard that utilizes the data that already exist within EHRs. So, I mean, it's quite brilliant. So thank you very much, Michael, for sharing your expertise with us today. I certainly learned a lot listening to you, and I think listening to you explain it, I think the value to me seems even greater. So I really appreciate the time that you've taken today, and congratulations to you and your colleagues for successfully developing and validating the de-risk score, and it sounds like potentially deploying it to the masses. And as adoption and implementation grows, I'm sure that the impact will be felt for generations to come. So thank you again, and I encourage our listeners to read the full article in the May issue of Diabetes Care.
Let's move on now to our rapid exchange segment, where Mike and I chat about some of the articles we found particularly interesting this month. Mike, can you start us off by telling us about your paper in Diabetes Care this month?
Well, thank you, Alice. Yes, I had the privilege of working with a group of investigators from the Collaborative Islet Transplant Registry and the Type 1 Diabetes Exchange Registry to compare glycemic control and kidney function over 5 years among individuals with type 1 diabetes who either underwent islet transplantation in the United States against those receiving ongoing standard of care in specialized diabetes practices. 71 islet transplant cases and 213 standard of care controls were selected for having experienced at least one severe hypoglycemia episode resulting in seizure or loss of consciousness in the year prior to enrollment in their respective registry. The primary outcome of achieving hemoglobin A1C less than 7% in the absence of severe hypoglycemia was met by 71 to 80% of islet transplant cases over the 5 years, compared with 21 to 33% of controls. And islet transplantation also resulted in significant reductions in and simplicity of insulin use, with the majority insulin independent over those 5 years. These benefits were tempered by a greater reduction in kidney function over time in the transplant group, an effect likely explained by the required calcineurin inhibitor-based immunosuppression. So these results should really help clinicians and patients more accurately balance the anticipated benefits and risks of islet transplantation, and also highlight the importance of current clinical trials now testing calcineurin inhibitor-free immunosuppression that can avoid potential nephrotoxicity.
So congratulations, Mike, to you and your colleagues for publishing this paper, and an important one, right? I think that really highlights the value that islet transplantation can bring. And I have to admit, it's perhaps because I'm working in the community, it's not top of mind for me when I'm seeing people living with type 1 diabetes, and perhaps it should be more so. Although, having said that, I am going to ask you a question. I realize this is rapid exchange and we're supposed to be rapid, but I'm still going to ask you a question. So, under the standard of care in specialized diabetes practices, how many of those individuals were on automated insulin delivery, or were all of them on automated insulin delivery?
Yeah, so at the time that these cohorts were monitored, automated insulin delivery was just rolling out. So while there was a significant increase in CGM use among the standard of care cohort over time in this cohort, and the majority were on, and an increasing majority on insulin pump therapy, they were not yet on automated insulin delivery systems. Although current updates from the Type 1 Diabetes Exchange Registry, which is since these data were collected in clinic based registry, there's now a virtual registry that has included individuals on automated insulin delivery. And we're still seeing a significant proportion of that group experiencing severe hypoglycemia and not reaching target A1C, who would have been comparable to the cohort studied here.
Okay, very interesting. So it'll be interesting to see. I'm sure you and your group will take another look at these registry data down the road to see what the difference is. But what you just said is, I'm a bit surprised, because I think there's this perception I have that automated insulin delivery will fix everything in the world, but obviously that's not the case. And that islet transplantation clearly still has a role. So again, congratulations on this paper. So my first pick is a curious association that needs an explanation. Dr. Huyu Zhao and colleagues from Peking University in China conducted a population-based study using target trial emulation to determine if there's an association between SGLT2 inhibitor use and epilepsy incidence. Based on the Yinzhou Regional Healthcare Database, they identified over 24,000 new users of SGLT2 inhibitor and over 28,000 new users of DPP4 inhibitor. During a median follow-up of 2 years, a total of 243 incident epilepsy cases occurred. After controlling for potential confounding, they determined that SGLT2 inhibitor use was associated with lower risk of incident epilepsy, with a hazard ratio of 0.71. A variety of subgroup and sensitivity analyses supported the primary result. The million-dollar question, of course, is how might this be explained if, in fact, the findings are replicated in other studies? So in the discussion, the authors offer some plausible explanations, including modulation of seizure activity through diminished glucose availability and decreased sodium transport across neuronal membranes, thus stabilizing neuronal excitability. Also, SGLT2 inhibitors have favorable effects on neuroinflammation, mitochondrial function, and oxidative stress, which may play a role. Finally, the lower threshold to achieve ketosis may be helpful, as ketogenesis has been shown to be helpful in the treatment of superrefractory status epilepticus. Bottom line, we don't know for sure, and confirmation is required.
Fascinating study, Alice. It will be really interesting to watch these potential mechanisms tested in future research and see whether any additional potential brain benefits are uncovered. Now, after you're calling me out, Alice, I wanted to call out a paper you were involved in together with Dr. Kansak Boonpattharatthiti from Narasuan University in Phitsanulok, Thailand, and colleagues. We heard Professor Geremia Bolli this episode discuss his review of the current role of basal insulin therapy for individuals with type 2 diabetes. And your paper now presents a comparative effectiveness meta-analysis of different strategies for titrating basal insulin on glycemic control in patients with type 2 diabetes. The strategy of self-titration twice weekly with healthcare provider support led to the greatest reduction in hemoglobin A1C without increasing the risk for severe hypoglycemia that was low across all studies. So together, the papers this month serve to remind us of the importance of basal insulin therapy in the type 2 diabetes armamentarium and provide updated data-driven guidance for its implementation. So thank you, Alice, and your colleagues for that.
Well, thank you, Mike, for discussing the paper. And yeah, I think it's a good reminder that where we are now with insulin, although its role has changed because of all the other therapies that we have available, it still has a role, and the importance of supporting our patients to do the self-titration. Because as I always say, our patients see us maybe, if we're lucky, 4 times a year, but they see themselves all day long, every day, forever. So it really makes sense for them to be in the driver's seat for that. So thanks for discussing that. My second pick is also along the lines of curious associations that need explanation. Ms. Danyang Wang and colleagues from Monash University in Melbourne, Australia, explored the association between diabetes and anemia. Using data from the US NHANES and the UK Biobank study, they performed a multivariable logistic regression to examine the cross-sectional association. Among white people aged 40 to 69 years from the US and the UK, the adjusted odds of having anemia was 2 to 4 times higher among those living with diabetes compared to those with normal glycemia. The adjusted hazard ratios for incident anemia were 3.05 for iron deficiency anemia, 3.02 for anemia of chronic disease, and 4.88 for B12 deficiency. When they adjusted for inflammation, renal dysfunction, and use of medications such as metformin, statins, PPIs, the association was only partially attenuated but remained strong and significant. This suggests that anemia may be a complication of diabetes itself without a clear explanation.
Very interesting. And while we often ascribe anemia affecting our patients with diabetes to other diabetes-related complications and medications, there may appear to be this direct relationship, and it'll be important to know now whether glycemic control affects this relationship as it does for other diabetes-related complications. And sticking with diabetes-related complications, Dr. John Ostrominski from the Brigham and Women's Hospital and colleagues conducted a pooled analysis of the non-steroidal mineralocorticoid antagonist finerenone trials of heart failure and chronic kidney disease that involved over 15,000 individuals with type 2 diabetes. Finerenone consistently reduced adverse kidney outcomes, cardiovascular events, heart failure hospitalization, and mortality in individuals with type 2 diabetes, irrespective of baseline measures of glycemic control or their use of glucose-lowering therapies. So treatment-related hyperkalemia rarely led to discontinuation, and its incidence appeared lower for those treated with a sodium glucose cotransporter 2 inhibitor or a glucagon-like peptide 1 receptor agonist. So importantly, the benefits with finerenone on renal and cardiac outcomes occurred even for individuals already prescribed these drug classes, as well as angiotensin system inhibitors. And this further supports consideration of finerenone as one of the pillars of therapy in the treatment of cardiorenal metabolic disease.
And it's so nice, I would say, in the last decade, right? I mean, the field has really exploded in terms of evidence for therapies that provide outcome benefit and truly reduce complications for people living with diabetes. So this is, again, excellent news. So my final pick is heartwarming for those of us with a soft spot for metformin, and I certainly do have a soft spot for metformin. I always say metformin is still an endocrinologist's BFF, or best friend forever, I think. So Dr. Suzanne Thierry and colleagues from the University Hospital Basel in Switzerland investigated whether metformin could prevent glucocorticoid-related toxicity. They performed a single-center, randomized, placebo-controlled, double-blind crossover study comparing metformin to placebo during high-dose glucocorticoid treatment in 18 lean, healthy males, so people not living with diabetes. The participants received prednisone, 30 milligrams a day, in combination with metformin or placebo for 2 7-day periods. Pre- and post-insulin sensitivity, mixed meal tolerance testing, blood metabolomics, and RNA sequencing of subcutaneous adipose tissue biopsies were performed. Metformin appeared to increase insulin sensitivity, alter fatty acid flux in the blood, and downregulate genes involved in fatty acid synthesis in adipose tissue. It also reduced markers of protein breakdown and bone resorption. There was also a downregulation of genes responsible for AMP kinase inhibition and impacted GLP-1 and bile acid metabolism. Therefore, metformin appeared to have favorable effects, addressing some of the downsides of glucocorticoids, even in a population who does not live with diabetes.
This was a very nicely done mechanistic study, Alice, and suggests we indeed might think of metformin use in the prevention of glucocorticoid-induced hyperglycemia and diabetes, just as we do and have seen its effectiveness in prevention of type 2 diabetes amongst those with prediabetes. Well, this brings us to the end of the May 2025 episode of Diabetes Care on Air. Thank you to Dr. John Buse, Mary Beth Cassely, Michael Bowen, and Professor Geremia Bolli for sharing their expertise with us.
And a big thank you to you, our listeners, for listening. Remember that Diabetes Care is continuing to take submissions of original art for consideration to be included on a future journal cover. Don't forget to subscribe to get notifications about new episodes of this podcast. Thank you for listening.